Us today. I'm delighted to introduce Charlotte Lowe, who's going to be speaking to us today, who is a paediatric neurodisability registrar, although you are actually an ST7, aren't you? So almost at the end now. If anybody is able to keep their cameras on, I know lots of you are in practice and not able to have cameras and mics and things. It's always nice because it means it'll feel like Charlotte's actually speaking to people. So do put your mics on if you can. Put your cameras on if you can, mics off. And if you've got any questions as we go, do pop them in the chat and we'll answer if relevant as we go and if not in sections. If while we're going through the talk, you think of any cases that you've had where you've not really known what to do in general practice, that's really useful for the discussion at the end. So do write down any cases that you think of and bring that to the discussion at the end. And the session will be recorded. So obviously just be aware of that if you've got your camera on. If you're not happy to be recorded, then in that case, turn your camera off. Brilliant. So Millie, do you mind starting the recording? And Charlotte, I'll hand over to you.
Well, hello everyone. Thank you for the introduction. I'm Charlotte Lowe and I work in community paediatrics here in Bristol. Can you hear me okay before I carry on? Yeah, got my headphones on because I'm in a joint office. So I've been tasked to talk about developmental delay and I'm really keen that this is relevant to you as possible. And so please do chip in if you've got questions and I'll try and address those in the breaks. So this is the overview of the session that we're going to cover. I'm going to briefly talk about what developmental delay is, then go on to clinical assessment for this, think about acceptance criteria and red flags, referral pathways, and then community support and resources. And each of those 5 sections, I'll give a little pause after the section in case you've got any questions. But if you just write them in the chat as we go along, Ruth's going to keep an eye on that as we go along. So what is developmental delay? There's a broad range of definitions on the internet, but essentially the main features are that it's when a child takes longer than other children to reach developmental milestones or doesn't actually manage to attain those developmental milestones, or when their progression slows down, stops or reverses. And our local definition in our CCHP developmental delay pathway is when a child shows significant delay over 2 standard deviations below the mean in 1 or more developmental domains. Obviously, that's a little bit subjective and hard to measure if you're not sure what the mean is. Just to remind you what the developmental domains are, for the sake of this presentation, in England, we generally look at the development in these 4 domains: gross motor, fine motor and vision, speech, language and hearing, and social, emotional and behavioural. And then cognitive development sort of encompasses all of those 4 and it can influence all of those 4. So when we're looking at developmental delay or impairment, which I'm going to talk about in a moment, we're talking about each one of those, a specific domain or several domains. So the word delay is actually a little bit tricky, really, and probably not very helpful for the general population and could be quite misleading to parents. If you say delay, it implies there's a pause or a catch-up. So if you're waiting at a bus stop for a bus, you get on the bus, even if the bus is a bit late, you get to the final destination in the end. There's no harm met. And actually that can be quite hard to unpick with parents who expect their child is just going a little bit slower, but will get there in the end. Actually, when we're looking at development, there's a wide variety of possibilities. The final destination for that child may not be the same as for another child, and the trajectory and the route they take again may be different. To illustrate this, I'll give you pictures of 3 children here with disabilities, and they probably would be defined as having global developmental delay or global developmental impairment. So each one of them have got difficulties in more than one domain, but actually the path they take will be very different. The boy with cerebral palsy here, shown here, it's unlikely that he will ever walk, looking at the level of support he needs for his neck and his age. So he will always be delayed in his gross motor skills. he may or may not have impairment in his cognitive development. The boy with Down syndrome with the hearing aid, he's quite young and it's been picked up that he's got a sensory neural hearing loss, which is excellent because without that intervention, his developmental trajectory would be a lot poorer. So it depends on picking things up early. And then the boy with the blindness, actually children who've got visual impairment, generally they're slow to develop because they're not getting their visual cues from the environment around them. But and those who are not cognitively impaired can do actually very well in the end. So just to show you the different trajectories within this term developmental delay. And we've got the influence of genetics with conditions, underlying conditions. Injury, for example, in cerebral palsy, the vast majority are caused by insults or injuries within the perinatal period. The environment that the child's brought up in and the amount of nurturing and intentional parenting, and then the interventions that may be provided. And this diagram here from quite an old, well, not all that old, paediatric paper from 2017, just was showing the trajectory for different, for one child in different circumstances. So if on the oblique line is normal, if that child had a non-progressive insult in later life, so for example, some head injury from an accident, they may have already gained many skills and then plateau off at that level. If that insult happened in early life, for example, in utero, they may never gain the full extent of the skills that they would have done if they had not had that insult. And then the important thing to not miss, which is the ultimate red flag really, is the developmental regression. So a child who starts off developing on a good trajectory, and then their development slows off and then goes downward, and ultimately generally would pass away at an earlier point than expected. All of these different trajectories are, and the pictures that I shared before, and I've mixed the two terms to be honest, because I usually use impairment. This is developmental impairment rather than delay. So delay implies that things are going to turn around and change. Actually, we're saying development's impaired. And research has shown that between 10 to 15% of children have developmental impairment in at least one domain of development. So it's relatively high numbers. The global developmental delay or global developmental impairment is a lot smaller population, but these are the ones you really don't want to miss. So 1 to 3% of the population are thought to have global impairment, and that's when there's 2 or more domains, and usually there's a cognitive impairment. Not always, but usually. Generally, we would reserve that term for the preschool child. And once they're at school and we can map their learning against the curriculum, for example, we would generally call those children, we would label those children as having a learning disability. So any questions from that first section that's popped up at all?
No questions at the moment, although I do have one, which is learning disability. If they didn't have cognitive impairment, but they had impairment in other areas, would you still call it a learning disability?
No, you wouldn't.
I think of that as very cognitive.
Yeah. Learning disability is definitely the cognitive aspect to it. I think what I'm trying to say is it's a bugbear of mine when I see a child with a significant learning disability who is not labelled as having learning disability, but on all their notes saying global developmental delay. Actually, that doesn't really explain anything. What's more helpful is to say a child has got delay or impairment in the following domains, so motor and language, or global developmental impairment. It's very rare, to be fair, that you have a global developmental impairment without cognitive involvement, because essentially to get a global involvement, you've got something that's impacted large areas of the brain, and to then not have any cognitive impact is rare. We do see it sometimes. I've got a child with cerebral palsy on my caseload who's not got cognitive impairment, but his cerebral palsy is less severe than what the severe disability usually is associated with the cognitive impairment. So you're right, there's always going to be exceptions to the rule. The point I guess I'm trying to say here is global developmental impairment or global developmental delay. If the child has clearly got a learning disability, that's what we're talking about when they're a school-aged child. As an adult, they won't be called global developmental delay. They'll be called learning disability or impairment in motor abilities. So we should be moving to that within the school-aged child. Does that sort of clarify that?
Brilliant, thank you. But no other questions at this point.
Okay, so moving on now to clinical assessment. So 3 parts of clinical assessment. One is your history, and then the second part, an extra part really for developmental assessment, is thinking about what is normal and is there any impairment? What is the development actually okay? Is it not? And then thirdly, examination. The developmental assessing whether it's normal or not will feature examination and history elements. So just some key history questions. First of all, take parents' concerns seriously. Generally, a parent has thought they've got concern about their child, and they've generally quite often taken a while to pluck up the courage to come and see someone about it. They will have seen other children they're comparing with them. I'm sure you're all very compassionate GPs and do this, but sometimes parents are going to have seen things that is a lot harder to pick up in a 10-minute appointment. So it is worth taking them seriously. In terms of history, especially if you're thinking of a more global impairment, it's important to go into detail with the antenatal, birth and neonatal history. I've got another slide going into that in a bit more depth. I'll talk about that in a moment. Then obviously your medical history to date. And going on to the family and social history, consanguinity is quite an important element for genetic diagnoses and metabolic diagnoses particularly. And then just finding out a bit about the family. We're not expecting an Einstein to be born from a family who neither parents have managed to attain their GCSEs. So try to balance whether something's normal for this family, but also using your knowledge of the family and of any safeguarding concerns to think, could there be neglect involved here? And remembering that maternal mental health can also impact on early development. Then the history questions, further history questions, we'd think about milestones. And generally a way of structuring this would be looking at each domain and saying, yes, they can do this, but they can't do this. So you kind of can pinpoint where their developmental ability is. And importantly, as I said, it'd be very rare that we get regression, but actually if there's regression, which is by definition, loss of previously acquired developmental causes. I've written the wrong word there, apologies. Loss of previously acquired developmental milestones over three or more months. This is really important and merits an urgent referral. This is quite a busy slide, just showing some of the factors that you can ask about in the antenatally, perinatally and postnatally. I've put some in different colours just to group it and make it a little bit more amenable to remember. But essentially, if you ask a family whether any problems in pregnancy, hopefully they will pick up on these effects or on these main issues. The ones I've highlighted, so infection and trauma and any safeguarding issues, those quite broad areas. If you keep those in mind and think about the 3 areas, and then thinking about if there's any other health problems in the child or in the mother, and family history, then you pretty much covered it all really. So going on to milestones. So I remember as a med student being told to familiarise myself with what was normal, and it felt like a massive job. And looking at milestones in isolation, for example, motor milestones like this can be quite hard to remember. It doesn't feel particularly intuitive if you don't have children of your own. And to actually get the dates right, it can be quite difficult. So in general, I'd suggest thinking about development across the 4 domains. For example, here, this table was just taken from PGDIP in paediatric neurodisability, but there's lists, lots of lists everywhere, but you're welcome to use this table if you find it particularly useful. So here, on here, actually, if you are able to sit with support, you can't have head lag. You wouldn't be able to sit without, if you've still got head lag, you're not really able to hold your head properly. So those fit together. And actually, you're then able to use your hands because you can sit, you can then reach out, and you're then developing your palmar grasp. That's the first bit of reaching out. Then you've got your hands in front of you and you can transfer objects from hand to hand. You kind of build the picture of the child in your mind, and then that you may be finger feeding again with using your hands. It's a bit crude, but it's just, if you think about it across the 4 areas, it's a lot easier to then see where there's something that sticks out and isn't quite normal. Another model that I know some GPs find useful is the Denver chart, which you can download from the internet quite readily. I'm sorry, this hasn't projected particularly well. Essentially, how this works is you draw a line for what the child's chronological age is, and then you can check whether they're reaching particular skills. And it's got the mean and then the standard deviation within those ranges. So you can tick off whether they've got particular skills and see whether they're roughly in line with each other. Just to be aware that the Denver has been looked at in studies, and it has a high sensitivity but limited specificity. So potentially you may it may produce a high over referral rate, but actually if we were going one way than the other, that would probably be preferable, because we want to assess children early who've got developmental concerns. And thirdly, another useful way of finding out if children have got development, if within your busy clinic, is to ask if you're not sure. Obviously, if you're sure, refer straight away. But if you're not sure, the childminder or nursery, if they attend those, will be following a early years curriculum such as Development Matters, which is on the gov.uk website. But the childminder or nursery may be able to give you some information about the development. If they don't go to nursery or have a childminder, another really important resource is the health visitor, and I'd advocate that you contact them anyway. They have an ages and stages questionnaire that they use for screening at about 2 to 2.5 years. It's actually a parent completed child monitoring system. So it has to rely on the honesty and literacy of the parent, and also that they're able to pick up on subtleties. So maybe if there's a language concern, you have to bear that in mind when you're using this tool. But it's a great way of getting a baseline of where the development is. They also have specific questionnaires at each age, so the health visitor can give them the specific age so they can measure against it. Just helps to provide a bit more information. The health visitor also can provide lots of support and signposting and some ideas about how to improve development and develop in different areas. So they're great to have on your side. So clinical examination for development. It's important. You really want to do a top-to-toe examination. I appreciate you have really short appointments, but one of the first things that's important is to know whether or not the child is well. I've had before a child referred with for development, I think failure to thrive, who actually was in cardiac failure, and the GP hadn't listened to the chest, and that's something you just don't want to miss. Does the child look well or not? If they don't look well, then community peds is probably not the first place you should be referring them to. And clues for development that can be helpful are looking at their growth. So in particular, their weight, and thinking about a trend compared to their birth weight, or their head circumference. Again, the trend compared to birth head circumference, which is notoriously inaccurate, to be fair. But looking at whether it's a very large head or very small head can give you clues, and whether that's in proportion to what the parents are. Then thinking about any signs of dysmorphism. Does this child look syndromic or not? Then your regular cardiac and respiratory and abdominal, just have feel of the abdomen. You don't want to miss signs of heart failure, for example, or a massive liver or spleen as part of a metabolic condition. That's something you really don't want to miss. And primitive reflexes we'll talk about in a bit more detail, and the neurological examination. And these are particularly important for motor concerns, gross motor concerns, and for developmental impairment across several domains. Checking that their eyes move or respond is again another sort of red flag area, because if there's cataracts, for example, and they don't have a red reflex, that's something that can be easily treated and will respond well to treatment. If the child has very small amount of response to any visual stimulus, then again, that's indicative of a problem with vision, and we want to get them seen sooner rather than later. So a neurological examination may sound a bit scary, but essentially you want to just take an eyeball look at them, think about what their tone's like, what is their posture, does the posture look normal, or have they got any of these signs that something else going on? Look at what their gait is like or their movement. Does this look normal, or is there something else going on? And another thing that's important to consider is just checking the spine. If you've got a child who's not using their legs properly, check the spine. Have we got anything going on at the bottom of the spine? And a quick thing about reflexes. So primitive reflexes, the Moro, the tonic neck reflex and the grasp reflex have all gone between 2 and 4 months. So if you've got a child who in which that persists, then that's a concern. The step reflex is usually gone by 6 weeks. So your 6-week check, I guess the step reflex is about gone. And the Moro reflex, you want to know, is it symmetrical or asymmetrical as well. So just having an idea of what's the norm for reflexes is helpful. The Landau reflex is holding the child in horizontal suspension with their head and legs, with their head and legs and spine extended. If you flex the head, then the knees and hips, the hip and knees and elbows also flex, and that's normally appearing about 3 months of age and disappears about 12 to 24 months of age. And it's absent if you've got low tone or very high tone. The parachute reflex, putting your hands out to save yourself, starts about 6 to 9 months and persists through life. I've put a bit more detail on the following slide about primitive reflexes, so you can look at it at your leisure after the presentation is uploaded. Any particular questions on that point at all? Or should I keep moving on?
No questions at the moment. Thanks.
Okay. So now looking at acceptance criteria and red flags. So as I said, developmental impairments caused by a broad group of conditions, and there's a consensus lacking on red flags. This diagram down here on the bottom left, I haven't designed for you to be able to read that, and I've got that separately at the end for your reference. This is what the Evelina Hospital are using for their reference as to who to refer. It's taken actually from the green and yellow handbook of the Oxford Handbook. So they have got quite a large number on there for their referral. But locally, we've sort of condense that down to a few areas. So the ones that were really vitally important that we don't want to miss, so our red flags as such, would be any sign of visual impairment. So not tracking, not smiling, not responding to any visual stimulus. So we want to see that soon, and they also will need to be referred to the ophthalmology at the Bristol Eye Hospital. Again, straight away. That's an urgent referral. Don't delay on that. Any neurological signs or symptoms. So obviously, if they're having seizures, their tone is abnormal, their head circumference is right at the very top end or very bottom end in conjunction with another concern. And then, of course, if there's any regression of skills, that child needs to be referred urgently. And then so those are next available. So then our urgent triage, or our prioritising triage, which is to be seen within 18 weeks. So bear that in mind when you're seeing the child. If you think, actually, I'm really concerned about this child, consider phoning through or highlighting it to our triage system. I'll show you how to do that in a moment. So, or we prioritise children who are under 2, those who've been discharged from neonates, those who have got child protection concerns, then hearing impairment, and then any motor function difficulty, excluding DCD or dyspraxia. And then looking at your remedy site, the red flags here listed was no smile by 8 weeks, persistence of primitive reflexes, not walking by 18 months, and development of handedness. And then they also talked about extreme preterms and specific genetic disorders as being priorities. So I tried to summarise that, and that includes the information from the Evelina Hospital in this table, which seems to have slightly cut off from the edge. I do apologise. Essentially, the yellow ones are the ones that Remedy have picked up. The blue ones were the ones that we have picked up. Essentially, if you've got a child with a gross motor concern, and particularly with neurological signs and symptoms, unless you're thinking more of a developmental coordination disorder, then that's a priority. If then the reason that you choose the not walking by 18 months is that you're picking up on the neuromuscular conditions, so that's the reason for that red flag. The persistence of primitive reflexes also feeds into the gross motor problems. So then looking at the visual impairment, no smile by 8 weeks, no fixing or following, having any sign of visual impairment, they need to be seen urgently. The hand preference on the fine motor and vision, I've put it under fine motor. Actually, hand preference is really part of gross motor, and that's the reason that you've got that as one of the red flags, is thinking about hemiplegia. So I think we've gone through those. Regression of skills. Regression of skills. Just if there's any regression, they need to be seen urgently. But then I've just included all the other ones, so you've got that for your information. But I appreciate that's probably quite hard to remember all these things. So try and focus on the key red flags, which I think has pretty much encompassed it all. Obviously, because it's a group of conditions, there may be particular red flags by condition. And I've put a summary of these at the end for your perusal after the presentation. But for example, in cerebral palsy, there might be a particular risk factor in the antenatal or perinatal history, motor delay and asymmetrical reflexes. Then metabolic, regression and organomegaly are particularly important. The hypotonia for a neuromuscular condition, and then this diagram here, I'm not sure how, depending how big your screens are, how well that's projected, but this is a picture of a child coming up off the floor from sitting and having to use their legs to move themselves up to standing. That's called a Gower's manoeuvre, and generally that's a sign of a neuromuscular disorder. And then don't forget safeguarding concerns. Failure to thrive can be caused by safeguarding issues. So just keep that one in the back of your mind. I was going to move on to pathways now, unless there's any burning questions on that.
No, you're good. Carry on. Yeah.
Everyone's very quiet. Oh, did I just no, thought I'd missed one. So who can refer to community peds? Well, quite a lot of people. They used to have parents in there and that's been taken out. But allied health professionals, consultants, the GP and the SENCO can all refer to community paediatrics. Why do we bother referring? Well, early detection and intervention improves outcomes. We want to do a diagnostic workup, essentially part of our history examination, doing a formal developmental tool, and then thinking about bloods or scans or any other specific areas to try and bring together a diagnosis. And that's got so many benefits for the family. And then just getting them into the right treatment pathways and getting the support they need. To refer, there's a single point of entry form, and here's the link here on the top. And at the bottom of the form, there's a tick chart that you can choose who to refer to. So particularly for developmental impairment, you'll be choosing, if you've got a global kind of picture, you'll be choosing community paediatrics. If it's just in a specific area, it may just be sufficient to choose, for example, speech and language therapy for an isolated speech deficit. If you've got a child who seems to have difficulties across the board, so for example, a global developmental impairment, for example, in a cerebral palsy, it's best to tick all the ones that you think are relevant. They will be the outcome will be decided by whoever triage is. The reason it's best to tick them is actually there's different weights and different services, and we have in the different patches it works slightly different, but for example in South Bristol we meet once a month with the whole MDT and we discuss referrals that have come in. So if a child has been accepted under physiotherapy and they're concerned there's quite significant needs, then they can highlight it at that meeting, and then that indicates to the paediatricians that they need to triage that child urgently. At the moment, unfortunately, we do have quite significant weights on our triage. I'm not sure of the latest, but for that reason, if they need more than one service, then please ask for more than one service. There's such a thing as a prioritisation request form, and the one that's relevant, this is where, if you put that into the Serona website, you'll come up with a prioritisation request form. This is the one that's relevant to developmental delay. So putting information in that's listed on this request form in your initial referral will help to get them triaged appropriately. You can also email this email address at the bottom here and send information in at a later date if things have got worse or have changed, or if you want to highlight that you think a referral is particularly urgent, it's probably worth emailing into this email address at the same time as sending in your referral to hopefully bring it to the attention of the team. And just to think about this is thinking about the co-referrals by domain. So for motor disorder, physiotherapy would get involved. If you're concerned there's significant neurological symptoms or the child's acutely unwell, perhaps they're having very regular seizures, then neurology would be very appropriate to refer to. And you may choose to refer to neurology and community paediatrics because our roles are quite different. I think if you've got an isolated neurological problem such as epilepsy is not in the context of developmental impairment, then neurology would be appropriate. But when you combine it with developmental impairment, actually the community paediatric team are able to offer a lot more in terms of advocacy and working with the school. They offer different things. So you may consider referring to both. Fine motor concerns, occupational therapy and vision check, so essentially ophthalmology, speech and language team, Always helpful to get a hearing test done on the child. Simple things to be excluded, and obviously if you've got any specific concerns to refer to ENT. Just a point here about bilingual families. We'd expect a 3 to 6 month delay in language in a child who's a part of a bilingual family. So anything above that would be concerning. Social concerns, you refer straight to the Autism Hub. If there's concerns that are fitting with a diagnosis of autism, but the child is also delayed in many domains, so we've got more of a developmental impairment, then you would refer both to the Autism Hub and to community paediatrics. They're two separate pathways. They're dealt with really differently currently. That's the model that we have at the moment. And so you need to refer to both separately and probably on a separate form to be emphasising separate things, which I know might feel quite painful. Just to be aware that there may be cultural norms with the child. So on just a really basic level, it's normal in India to eat with your hands. So your child wouldn't be able to use cutlery particularly, for example. So just make sure that you're thinking about those things as well. And then if you've got multiple domains that are affected, so 2 or more, you can refer to Portage, and they're an excellent source of support for the preschool child. And I'll tell you a bit more about Portage in a moment. I'm just going to keep moving on actually, because this sort of links in with this. So here's some community support and resources that are available to you. So the health visitor, as I said, can offer early help, signposting, a bit more of diagnostic information. They've got better links with children's centres and trying to get families linked into the right support. Don't forget social care support. So Families in Focus through the government, through the council websites, just bearing in mind that a child with a disability has got an increased risk of abuse. It's more stressful bringing up a child with disability, and picking things up early is helpful for families, giving them the skills they need to parent that child. And our website now has an excellent resources signposting area. It's built primarily around neurodiversity. Actually, it's a lot more than that now. And I've just highlighted some of the areas that are relevant within developmental impairment. So the parent care information, so Send and You is linked to that. And the local offer, which is now called Flora, just to keep you up on your, keep you awake, all these changes. And then Portage as well is also linked to that. Also in there's lots of resources about neurodiversity, emotional regulation, behaviour, mental health, a specific section on speech and language therapy and trauma. So just to talk a bit more about Portage, this is council-run educational support for 0 to 4-year-olds. And you can be referred by any professional or the parent. The child just has to have at least two areas of delay or impairment. And in Bristol, they need to not be currently in an educational setting. That's different in different areas. So South Gloss, they can be referred if their preschool attendance is less than 10 hours a week. There's a waiting list in place, so they may not get in there straight away. And Portage essentially consists of home visiting service where they're doing specific targets for that child, and giving them ideas for play to support development, and supporting the parents about special educational need processes and procedures. But then there's also drop-in groups, which you probably would be able to access a bit sooner than the home visiting service. And for example, these are the drop-in groups here for Bristol, and there'll be similar ones for South Gloss and North Somerset. And then other resources for families. The government has brought out a non-statutory curriculum for the early years foundation stage called Development Matters. It's quite a long document, but there's other sites called developmentals.org.uk has a downloadable reference that you can also send off for as a book, and it has different milestones and activities to support development. So if you've got a worried parent who and there's sort of minor delays in one area, this is the sort of resource that can help them to support their child. I actually think that the one in America called pathways.org is probably a little bit easier to navigate for parents. They've also got an app, and it has red flags for when a parent should be asking for referral. Just to be aware, I've put there the domains that they talk about, so which are listed there. They're slightly different to the ones that we use in England. They're all really relevant, but just to be aware, and some of their referral procedure or what they call things will be slightly different to England. So just to use that as a caveat. The personal child health record, which everyone's got, has actually got some checklists in. So if there's a problem with vision or hearing, or if there's concerns with development around the stage of those 4 key checks, then there's checklists there. They're quite brief, but that's something that you can show to parents and help them to reassure them that their child is normal, for example. And then if you've got a child who is diagnosed with disability or obviously has disabilities, MenCap is the charity for learning disability, and Contact is an excellent umbrella charity for families with disabled children, offering lots of different support about support groups and benefits and having a child with a special educational needs. They're a really good resource to give to your parents. Lastly, I've collated a few resources for professionals. So again, the Sirona website for the advice and signposting has got some excellent resources on there. If you're interested in looking at how to examine children at different ages, this website here, I've just put the QR code, goes through different developmental milestones and examination, including looking at the primitive reflexes, and that can just help reinforce that for your own training and acumen. Disability Matters is an excellent website for e-learning and giving you a bit more background information, and BACD has online talks and different events if you're interested in taking it further. And at the bottom there, I've just put again the referral link to get through to the referral page for making a referral. Just to summarise what we've talked about today, we talked about what is developmental delay or developmental impairment, how can we assess it clinically, what are the red flags or acceptance criteria for developmental impairment, some of the referral pathways, and some community support and resources. And there's time now for any questions, and I'd really be grateful if you could fill in my feedback form, please. I can't actually see any questions.
Can I ask a question?
Yeah.
Around the developmental milestone sort of red flag of being able to walk by 18 months, there's often lots of chat about if they're moving by other forms, for like bottom shufflers and that sort of thing. Would you still expect every child to be able to walk by 18 months, no matter if they found another way that works for them? Is that your absolute cutoff?
I think 18 months is the time when we think they should be referred into our system. You're right that bottom shufflers tend to walk later, but essentially we don't want to miss a neuromuscular disorder. And essentially the main thing that we want to do, just check if there's anything going on with the hips so that we've missed, and do a CK. So I guess it depends how comfortable you feel holding that risk. And sometimes I see a child who might arrive at 18 or 19 months and starting to cruise around the furniture, and we decide that we'll just do some watchful waiting for a few months. And I guess that could be acceptable in GP land if you feel you've got that capacity. But if you're not sure, definitely refer it in. And if they've got bottom shuffling, then they may well normalise. If you're confident that their motor examination and neurological examination is normal, it's a lot more reassuring and there's nothing else going on. If you've got the capacity to do that extent of assessment in primary care, then that would be okay to hold on for a bit longer. I think you've got to bear in mind as well that we've also got really long waits at the moment to be seen, and I mean up to a year for some of these children, and so you can always refer and then retract that referral later if the child starts walking. You don't want to miss something if we can provide input early. So that would be where I'd stand on that.
Thanks. And are you able to see the chat or not at this point?
No, I can't.
No,
I don't know how to.
No, that's fine. I think if you're presenting and you've got one screen, you won't be able to. So there's another question as well. I've read that being bilingual doesn't cause speech and language delay, but you said otherwise. Could you clarify a bit more, please?
Oh dear. Quite possibly, I don't know fully. I think the thing that I read in my clinical experience, children who are bilingual tend to start talking later, but they will talk fluent. So I'm interested that this person's read otherwise. I picked that up. The 3 to 6 months I picked up from one of the research papers I got, and I can't remember the exact reference, unfortunately. If you've got delay longer than 3 to 6 months, then we would be concerned about it, would be the way to spin that. I expect there's going to be some bilingual children who don't have any impairment. I've consistently seen children who have language impairment and they're bilingual, and actually over the course of time that just normalises itself out. So yeah, I don't know. Without looking at the merits of those two references, it's hard to make a further comment on that. Sorry.
Sorry. And there's another question. Do many referrals come from GPs or usually from other healthcare professionals or other professionals?
Yeah, I'd say we get a mixture. I think health visitors quite often are well placed to make the referral, especially if they're picking it up in a screening questionnaire. So there's a mixture. I'd say for the developmental impairment, it's whoever's seen the child who's got the most information. It's helpful that the GP's seen them to do a head-to-toe examination, so you're not missing out on something that's treatable or a health problem that needs attention. So, but we do see a lot of referrals from health visitors.
Another question as well. So often children who've got faltering growth have gross motor development delay. In those sorts of cases, would you want us to be referring to general paediatricians to be looking into the faltering growth first, because that obviously is likely to have a knock-on impact on development, or would that be two referrals hand in hand?
I think I would probably do them to both referrals. I think unless you're, yeah, I think the general paediatricians generally don't do the detail of developmental assessment, and we get referrals from them in this type of children. I think it's trying to work out how concerned you are. I don't know whether you can give a bit more of an example of a case to kind of put a bit more meat on that question.
So I'm thinking of a little one who I saw recently who was 2 and had lots of kind of background of calcinic protein allergy and other things, and had faltering growth that was basically put down to that and was slowly catching up, but had an isolated gross motor, always sort of like on the cusp of hitting the red flags the whole way through, and started to go off the edge of that. And so that was sort of thinking with that one. So I did do both referrals side by side, but I wasn't really sure whether that was the right thing to be doing, or whether actually it should have just been the general paediatrician, because actually I think a lot of the things that he was struggling with were things like you know, walking upstairs and things, just because actually he was really quite small.
Okay, that makes sense. Yeah, if it's a height thing that's affecting the gross motor, but I guess if it's a tone problem that's affecting gross motor skill acquisition, then you're more likely to have a neuromuscular issue underneath, or a neurological problem underneath, and that needs investigating in its own right. You're right. If you've got, we've had children, a very short child or child with achondroplasia won't be able to do some of those gross motor things in the same order, but they should still be able to the jump, for example, or walk well. If they can't reach it because of a mechanical issue, then that's not a useful milestone for them. And I think that's one thing when we're looking at milestones and assessing development, we have to always bear in mind, because a child may show up as having low development in a certain area because our assessment tool isn't specific for the impairment that they already have. It doesn't isolate it out, and that's why for visually impaired children we actually have specific developmental assessment tools that take into account their visual impairment and then work out whether their development is appropriate for a visually impaired child. And we're missing that sort of level of detail in a lot of things. So I think there is a level of trying to work out what to do there. And I think if that child had some concerns about their use of their legs or their power in the legs or something, then it would be reasonable to refer to physio and say, I'm referring to the general peds for this, but I think this is all part of this. Can you just have a look? Because the physio would probably see them a lot sooner, clear that there's not an issue, and also have access to an OT who could provide, for example, seating or whatever to make up for that height difference. So perhaps go down that route if you're not sure. I think it's appropriate. What you did was fine.
And then one last question from the chat as well. How much communication is there between the ASD and ADHD services and the general community paediatricians? I asked because I've seen a child referred by school for ASD, and I wondered whether it was more of a global delay. Would that get passed over to the correct team?
How the service is set up at the moment, this is tricky to answer. I think ultimately they've been put into separate pathways is how the service is set up at the moment. Ultimately, in the Autism Hub, you can be seen by a paediatrician, but you could also be seen for most of your assessment by other professionals who are not paediatricians, who therefore would not be able to give you an assessment for developmental impairment or to assess for ADHD. When you're going for an ADHD assessment, you see a paediatrician. So that person has the competencies to think outside the box and to be thinking, actually, this could be ASD or this could be developmental impairment. And when you get referred for a developmental concern, that person has got the potential to think about all three. It's difficult because of how the pathways have been put like this, and there's talk about combining pathways and thinking, but that's the current model at the moment. I think if you've got further concerns and you think actually the referral I made it doesn't really cover those, then you can always send in further information with the form that I shared. So further information to support your referral, or to say, actually, I think we've got another issue going on here. For ADHD referrals and for autism spectrum disorder referrals, there are some there's paperwork to be filled out by the school and by parents before they are accepted or declined in triage. So that would be further information that would need to be sent in. I hope that helps. I think at the end of the day, it depends on who sees that child first. If my personal practice, if I see a child who has waited a year for an assessment and they're in the wrong bucket, they call them buckets, then I try and do the assessment for all three. But that's having to do that in my own time outside of the clinic capacity, and that's really the challenge. So sometimes if you see someone, for example, for an ADHD assessment who's really got autism, then it's difficult to then backdate that referral so that they're further forward in the autism assessment. So better to do separate referrals if you think there's more than one thing going on, and that covers your bases. And we can always cancel other referrals when we see children if that's the case.
Brilliant. Thank you so much for that. Thanks very much, Charlotte. That was a fantastic talk, really useful. And I particularly liked the details on referrals and different types of referrals that we can do and all those resources. So that was really useful. Brilliant. Thanks very much. Millie, would you mind popping the feedback form in the chat, and we'll send the results of that over to you when we get them back, Charlotte. And I just want to steal the last couple of minutes to let everybody know what's coming up. So I'm just going to share my screen. Great, so I'm hoping that you can see that, but if you can't, Millie, would you mind shouting up, because I won't be able to see the chat at this point. So a heads up to the next session. So the next session date for the diaries is Tuesday the 18th of June, and we've got Gemma Tabut coming to speak to us, who is a physiotherapist, and she'll be speaking about infant MSK, so specifically looking at feet and hips. And I believe that Millie is currently putting a sign up link for that in the chat. So if you wanted to sign up now, you can. Otherwise, the sign up link will be in the What's On tab in the Training Hub website and on the Child and Young Person Educational page. So I expect by now you're all well aware of this page, but if you Google BNSSG Training Hub and click on the Resources tab, there's a Child and Young Person Education page where everything is in one place. So you can see the monthly BNSSG Peds podcasts that are being released, these CYP Educational Forum sessions that you can sign up to, and any sessions that you've missed in the past and you want to play back the recordings, the recording library is there. And there's also a mailing list at the bottom. So if you want to be emailed when there's things coming out or face-to-face events coming up, then you can. And the last thing to highlight before I let you all go is that there's some really exciting new changes to Remedy. So we talked before about the urgent care pathway for the suspected cancer referral pathway for children and young people. It is now live. So they finally finished the page and it is up there, and it looks, so this is just the start of it, but it looks absolutely fantastic. So they've broken it down into different types of cancer. So there's a section on lymphoma, leukemia, Wills tumour, brain tumours, etc., etc. So that is one to check out. We mentioned last time, but the new continence service. So we've got a really brilliant new continence service in Bristol, which is now matching the service that, so it's now the same across Somerset, South Gloucestershire and Bristol. So bringing it all up to the same level, which means that we can refer for less complex issues, which makes a really big difference. So there's a single point of entry form there. And there's a couple of new guidelines that have come out as well under Bristol Children's Hospital. So the guideline of management of lymphadenopathy in children in primary care is a really, really useful resource. So that's a good one to check out. And a new one's just been released on labial adhesions as well, which is nice and succinct and makes it all very nice and simple. So another one to have a look at. And then finally, so this is not a free event, but for anybody who's interested, particularly anybody who works in urgent care, so out of hours, the A&E department, or depending on the work that you're doing in your GP practice, there's an event called All in a Day's Work, which is based in paediatric emergency and urgent care, and that is in September. So another date for the diaries, but you can Google All in a Day's Work and that will come out as an Eventbrite ticket for anyone who's interested. Brilliant. So I will stop sharing. Thank you so much, all of you, for joining, and we look forward to seeing you next month. Please do fill in the feedback form before you leave.